So patients with diabetes really need to have some nutritional therapy. Ideally, they're getting counseling, education, they're going to need ongoing monitoring, and it really should include an interprofessional team such as a registered dietitian who has an expertise in diabetes management. The American Diabetes Association encourages healthy food choices that help to maintain blood glucose levels as close to normal as possible. One of their other goals is to have normal lipid profiles and blood pressure. This all helps to prevent or slow complication, but we have to think about the individual needs. There's personal issues, cultural preferences, and we don't want it to be so restrictive that they no longer enjoy eating. So as with when I think of diabetes and planning, I think about all of my life trying to lose weight, and it's all about meal planning. So really want to base the meal planning on usual food intake and preferences, balance with that insulin and exercise. We want to see that they're getting some day-to-day consistency. That makes it easier to manage that blood glucose levels. They do have a little bit more flexibility with rapid-acting insulin or multiple day injections and the insulin pump. Again, with type 2 diabetes, the emphasis is on achieving glucose, lipid, and blood pressure goals. For this person, it may likely include weight loss. And so we want them to have nutritionally adequate meal plans with decreased fat and carbohydrates. They're going to want to space their meals appropriately and get regular exercise. And we'll talk more about the exercise in just a bit. So what somebody's choosing needs to be foods that are full of nutrients, not those empty carbs or empty calories. We want to make sure that what they're taking in is balanced with their activity levels, and it's going to need to be individualized based on their lifestyle and their health goals. Now, I know this next slide is usually surprising to students. Patients who have diabetes need a minimum of 130 grams of carbohydrates a day. Ideally, these carbohydrates are coming from fresh fruits or even canned fruits, not in syrup though, in fruit juices, vegetables, whole grains, legumes, low-fat dairy. All patients benefit from including dietary fiber that's going to help decrease cholesterol. And then nutritive and non-nutritive sweeteners may be used in moderation. There is some thought that even some of those like saccharin or whatever the ones are used today can cause the body some confusion. So that's why those need to be used in moderation. So diabetic patients should limit their saturated fats to less than 7% of calories, should limit their cholesterol to less than 200 milligrams a day. And not all foods that are low in fat or low in cholesterol. An example of that, which I found interesting, is shrimp. Shrimp is low fat, but it is high in cholesterol. Want to minimize those trans fats and make sure that they're getting healthy fats, such as olives, nuts, avocados. Those are, and even those need to be limited. Avocados in moderation is good. Too much avocado is not good for you. Protein should be about 15 to 20% of total calories. High protein diets are not recommended, and part of this is because proteins can be hard on the kidneys, and patients with diabetes are already at risk for some kidney issues longer. We'll talk more about that in one of the future videos. Alcohol need to limit to a moderate amount, so 1 drink a day for women, 2 drinks a day for men, same thing that we talked about the other day. This alcohol inhibits gluconeogenesis by the liver, and it can cause severe hypoglycemia. So blood glucose levels must be monitored. And well, I don't want to say that because that would confuse you, so I'm just going to leave it there. So again, we really want the dietitian to provide the instruction. We're going to teach patients for carbohydrate counting. So a serving size of carbohydrates is 15 grams, and that equals 1 carb count unit in the hospital. So if you ever look at a patient's tray where it'll have like half a banana, and behind it it'll have a 1 in parentheses, that is saying that is 1 carb unit. So it's actually 15 grams of carbs, but in the hospital we're counting them as 1 carb unit. So typically a patient should have 45 to 60 grams per meal, so anywhere from that 3 to 4 carbs per meal, and that will again depend on the patient. And then the insulin dose needs to be based on the carbohydrates consumed. And so getting patients to understand carbohydrates is important. You know, so many patients don't realize that eating a baked potato, your body doesn't realize that the baked potato is any different than eating a Hershey bar. It's carbohydrates. And so teaching patients those things is really important for their success and their decreasing the risk for micro and macrovascular changes later on. So it's important that patients understand starches, fruits, milk, meat, vegetables, fats, what is considered a free food, meaning that it's okay, you could eat, so such as usually cucumbers. They have very little calories, and other than water, they really don't have much value other than the fiber that they'll give you. So consistent carbohydrate diet. The U.S. Department of Agriculture MyPlate method is the preferred, and this is an example of what that would look like on here. All right, so we've talked about exercise before. When we talked about PAD, we talked about the minimum amount of exercise, of aerobic exercise is 150 minutes per week. The patient should be getting resistance training 3 times a week. The benefits of exercise is it helps to decrease insulin resistance and therefore reducing that blood glucose. It can help with weight loss. It helps decrease triglycerides and LDL, our bad lipids, and it can help increase our HDLs, which are our good lipids. It improves blood pressure and circulation. Now, as with all exercise programs, patients should get medical clearance from their healthcare provider saying that it's okay for them to start a program. They need to start slowly. They need to monitor their blood glucose levels. Once they've exercised, they can actually have decreased blood sugars up to 48 hours after the exercise. Ideally, they want to exercise an hour after meal. And if they take medications that increase insulin or have that risk for that hypoglycemia, we want to make sure that they have a snack with them to prevent hypoglycemia. And really, any of your type 1 diabetics should always have a snack or candy or something if they would have that hypoglycemia symptoms. Patients should not exercise if the blood glucose level is greater than 250 and or if ketones are present in the urine. That puts them at a higher risk for DKA, and that's why high blood sugars, they should not exercise. So teaching patients how to check their blood sugars is important. It helps them make decisions about their diet, exercise, and medication. It's going to help them, when they do that, record any glucose fluctuations. It's going to identify hyper and hypoglycemia so that medications could be adjusted as needed. It helps to maintain glycemic control because they're seeing where they are. And it's an absolute must for people who are taking insulin. And the frequency of testing is going to vary. Again, somebody who's on insulin is going to test much more frequently than somebody who is a type 2 and on oral medications. There are some new blood glucose monitoring where people can do it on the arm. And that data is uploaded to the computer so the healthcare provider can see it. There's also continuous glucose monitoring. It displays the glucose values, updating every 1 to 2 minutes, and this often will go to like a smartphone. It helps to identify those trends and track patterns, and it will alert the patient if they have hypoglycemia or hyperglycemia. And I know that I've seen them use self-monitoring units in the ICUs now when somebody has has DKA, because we're getting that blood sugar continuously, and so that helps us to titrate that insulin to get them out of that DKA. Of course, we need to teach patients how to calibrate. Think about what we do in the hospital setting. They need to know when to test. Most frequently, it's going to be before meals. Sometimes they might be encouraged to test 2 hours after the meal for some of those medications we talked about. If they have hypoglycemia, they should definitely test and see. When they're sick, they are more likely to have high blood sugars, so we need to teach patients that even if they're not on insulin, that when they're ill, they should be checking their blood sugars more frequently. And then, of course, before, during, and after exercise, blood sugars should be monitored. Now, there are some other treatments that can happen. So bariatric surgery might be appropriate for patients with type 2 diabetes. The bariatric surgery is a massive undertaking, and not all patients are candidates, and there are a lot of complications with it. Pancreas transplantation is becoming a little bit more widely done. It may be considered for patients with type 1 diabetes who may undergo renal transplant or who have end-stage renal disease. There's also that pancreatic islet cell transplantation. It is still considered experimental in the US, but I know that they are still working on that. Now, we talk about being culturally competent as nurses, but it's really important to realize that culture is a strong influence on a lot of patients' dietary preparations and meal practices. Hispanics, Native Americans, African Americans, Asians, and Pacific Islanders have a high incidence of diabetes. So they have the increased prevalence, partially from genetic predisposition, environmental factors, and dietary choice. So we really want to consider the patient's cultural food preferences. The ADA is a good resource for patients, but I've had even students who talked about their family members who they weren't doing well with their blood sugars, and it's because of their culture and some of the foods that they eat. And so while we may not understand that personally, we need to respect that their culture is important to them and that we should not expect them to give up that part of who they are. So refer to the table for the nursing assessment. You guys have had nursing assessment. I'm not going to take time recording that. There's a lot of different nursing diagnoses that could be appropriate: ineffective health management, that risk of unstable blood glucose levels, risk for injury, that risk for peripheral neurovascular dysfunction, deficient knowledge, and there's probably even more here. We could go on and on with diabetes because it does affect the entire body. Again, our goals is we want patients to be able to take care of themselves and take care of their diabetes effectively. Hopefully, they're not going to have a lot of hyperglycemia or hypoglycemia emergencies. Maintain blood glucose levels at that normal or near normal levels. Big thing is trying to prevent or decrease those chronic complications, which will be in a future voiceover. They need to adjust their lifestyle to accommodate diabetes plan with minimum stress. And then they need to effectively fit diabetes into their life than living around diabetes. There's a table in your book about health promotion. Again, we really want to identify, monitor, and teach patients who are at risk. Obesity is a primary risk factor, especially with a type 2 diabetes. We really need to do routine screening for all overweight adults and anybody older than 45. We'll talk more about DKA and HHNS in another video. Again, remember that when somebody is ill or they have surgery, their blood glucose levels are going to be up, secondary to those counter-regulatory hormones like cortisol. They're going to need to frequently monitor their blood sugars. If their blood glucose is greater than 240, they need to do ketone testings of their urine. And they need to report glucose levels that are over 300 twice, or if they have moderate to high ketone levels, to their healthcare provider. Patients who have type 1 diabetes may need to increase their insulin. Again, they need to be talking to the healthcare provider. It's just like oxygen. You can't increase that on your own. And type 2 diabetes may need insulin therapy during an acute illness or surgery. Now, during an acute illness, we ideally want them to maintain as normal of a diet if they're able to. They need to increase non-caloric fluids, continue taking their anti-diabetic medications, and if normal diet is not possible, supplement with carbohydrate-containing fluids while continuing the medications. Now, intraoperative period, patients are going to receive IV fluids and insulin, and they're going to need frequent monitoring of their blood glucose levels. In the outpatient setting, we want to enable that patient or caregiver to be able to be independent in their self-care. Again, we want to try to let them know that they're at an increased risk for other complications, and they need to have good interactions with their interprofessional team. We need to make sure that the patient is able to do their own blood glucose monitoring and injections. We need to assess the patient and caregiver's knowledge and ability to manage their diet, medication, and exercise. They need to be taught how to identify hypoglycemia and hyperglycemia and what to do if and when those happen. Other important outpatient things, they need to do good oral care, foot care. This is huge. They need to inspect their feet daily. They should never go barefoot indoors or outdoor. Proper footwear, again, those rounded toes. Don't change their, get a brand new pair of shoes and then go on a cruise. They need to know how to treat those cuts. If they're traveling, they need to make sure that they have proper medications and supplies for their blood glucose monitoring, appropriate foods and activity, and really all diabetic patients should have a medic alert bracelet to identify that they are diabetic. Some complications that happen, hyperglycemia, not enough insulin is working, or hypoglycemia, there's too much. Acute complications, we're going to talk about this in a part 2, that would be like DKA and HHS and hypoglycemia. And I hope this voiceover was helpful for you.